Welcome to this explainer. Today, we're diving into a topic that honestly affects millions of men, but rarely gets the clear scientific breakdown it actually deserves. We're looking at ejaculatory disorders. Now, we're drawing straight from the evidence-based guidelines of the American Urological Association, and our goal here is simple. We want to show you the actual science behind how these reflexes work. We're going to prove that these are totally treatable, really fascinating medical conditions, and absolutely not personal failings.
So here's our roadmap for the explainer. First, defining ejaculatory disorders. Second, premature ejaculation explained. Third, treating premature ejaculation. Fourth, delayed ejaculation explained. And finally, number 5, pathways to better health. Let's just jump right in.
Section 1. Defining ejaculatory disorders, the biological baseline.
Okay, so if you were to literally take a stopwatch to population data, you might actually be pretty surprised. The median time to ejaculation for men in Western countries, it's just 5 to 6 minutes. And, I love this stat because it instantly grounds our expectations in reality, right? Climax is this highly coordinated, incredibly delicate spinal reflex. Knowing this 5 to 6 minute baseline helps us pinpoint exactly when a true clinical deviation happens. When that timing gets disrupted, it can cause immense frustration. But establishing what's neurologically typical, that's step 1 toward a real solution.
Moving on to Section 2. Premature ejaculation explained. The fast end.
Now, for a true disorder to be diagnosed, you need 3 distinct puzzle pieces present all at the same time. You need ejaculation within about 2 minutes of penetration, a lack of voluntary control, and, this is crucial, personal or interpersonal distress. Think of this criteria kind of like a funnel. Up to 30% of men will self-report having premature ejaculation just because they feel they finish too quickly. But when we filter that through these strict clinical criteria, less than 5% of men actually have the disorder. So it's really not just about the clock. That lack of control and the emotional toll are what truly define it.
And there's a massive difference between the 2 primary subtypes of this condition. You have lifelong PE, which means it's been present since a man's very first sexual experience, always keeping that latency under 2 minutes. But acquired PE, that develops later in life after a history of completely normal control. It usually features a 50% or more drop in latency time. And what's interesting is it's often triggered by other things, underlying health issues, maybe changing relationship dynamics, or even starting a new medication.
All right, Section 3, treating premature ejaculation, evidence-based solutions.
So, the secret to gaining control here actually lies in a specific neurotransmitter, serotonin. Serotonin acts as the body's natural brake pedal for ejaculation. By using SSRI medications to boost serotonin levels in the spinal neural circuits, medical science has basically discovered a biological hack. We can effectively increase the body's threshold, significantly delaying that climax reflex, and ultimately returning a real sense of control to the patient.
When we look at oral medications, there are generally 2 strategic paths. You can go with daily off-label SSRIs like paroxetine or sertraline, which slowly build up in your system over a few weeks to delay things. Or you can use on-demand options like depoxetine. Depoxetine is uniquely fast-acting. It has a remarkably short half-life of just an hour and a half, meaning it can be taken just an hour or 2 before anticipated intimacy. It peaks quickly, clears out fast, and successfully bypasses the side effects of taking a pill every single day.
But hey, for those who want to skip pills entirely, topical anesthetics are incredibly effective first-line options. We're talking sprays or creams, usually a lidocaine and prilocaine blend, applied directly to the skin of the penis. By slightly numbing local sensitivity, they dampen those really intense sensory signals traveling up to the spinal ejaculation generator. It literally cools off that reflex arc, safely extending the time to climax without affecting the rest of the body at all.
While medications are super powerful, behavior plays a massive role too. The stop, start, and squeeze techniques physically train the body to recognize that point of no return and hip toss before crossing it. Meanwhile, sensate focus is purely psychological. It trains the brain to focus on physical pleasure and connection rather than crippling performance anxiety. When you combine these behavioral therapies with medication, it's a real game changer. It empowers men to build natural, lasting control.
Okay, swing into the other side now. Section 4, delayed ejaculation explained, the slow end.
Despite the physical exhaustion and just the intense relationship distress it causes, delayed ejaculation, or DE, remains arguably the least studied, least reported, and least understood of all male sexual dysfunctions.
I mean, even the American Urological Association openly acknowledges this profound lack of clinical data. It's a condition where the reflex is far too inhibited. But despite the mysteries, the medical guidelines do still give us a clear framework to identify and manage it. So, DE happens when a man is highly stimulated, deeply wants to climax, but the reflex simply refuses to trigger. Diagnosing this, it's like putting together a really complex puzzle. Doctors have to carefully untangle whether the missing piece is insufficient physical stimulation, a deep psychological block regarding intimacy, or maybe an external chemical factor that's completely short-circuiting those neurological pathways.
And this right here perfectly demonstrates just how delicate our brain's neurochemical balance really is. Think of it like a seesaw. The exact same SSRI medications used to successfully treat premature ejaculation are actually a leading cause of delayed ejaculation. By artificially boosting serotonin to treat, say, depression or anxiety, the scale tips too far the other way, and the ejaculatory reflex becomes overly suppressed and just locked down. Which brings us to our final section. Section 5, Pathways to Better Health, Holistic Management. Because there are currently 0 FDA-approved oral medications specifically designed to cure DE, treatment requires a really comprehensive, holistic attack plan. This means working closely with your doctor to carefully taper off or adjust those culprit medications, like SSRIs. It involves testing for hidden underlying issues, like low testosterone, and normalizing that if it's deficient. And crucially, it means communicating with a partner to introduce new sexual routines or devices, like vibrators, to absolutely maximize physical arousal.
You know, these pelvic conditions rarely ever exist in a vacuum. They're all intertwined, constantly feeding into each other in this continuous cycle. For example, a man might develop acquired PE as a subconscious adaptation, literally rushing to finish his climax before he loses a weakening erection. On the flip side, the crippling performance anxiety associated with erectile dysfunction can completely block the mental ability to climax, causing DE. So thoroughly evaluating and fixing the underlying erection issue first, that often breaks the whole cycle and resolves the secondary ejaculation problem entirely. So I'll leave you with this question to chew on. How does understanding the neurobiology of sexual reflexes change your perspective on intimacy? When we step back and map out these spinal generators, the neurotransmitters, the strict diagnostic criteria, we completely remove the stigma. Sexual health isn't some reflection of personal adequacy. It is a fascinating, highly treatable physiological process. And it's a process that's best navigated with open communication with your partner and alongside a qualified medical professional. Thanks so much for joining me on this explainer, and I'll catch you next time.